Okay, so we have 3 presentations, is it?
Yes, Doctor.
Okay, all right. Okay, fine. Let's proceed with the presentations.
Okay, Bismillahirrahmanirrahim. Can you all hear me well?
Yes.
Okay, if anything, the problem with voice, just let me know. Okay, Bismillahirrahmanirrahim. My name is Hafifi. So, today let's discuss about the pale child, a pale child. So, next. So, firstly, I provide you the simple case scenario that you can imagine. 4 years old girl presented with lethargy and also pallor for 3 months. So as you can see, the child at the right side is quite pale, right? So this is a presentation of this patient. So this patient is a girl and a child which is 4 years old, presented with lethargy and also pallor. So I'm sure at this point, all of you have several idea about this patient, right? So next. So to how to approach this patient or case is as usual, we go through the history first and then physical examination, investigation for diagnosis and also management for this patient. So I will focus more on how to approach this case or problem in a clinical practice, not single disease or diagnosis. Okay, next. So a pale child. So in your mind, if a pale child come to you, so you must have the question: is it the pale due to anemia or others? So it is a important question must be in your mind. So is anemia or others? So next. Why? Because the anemia, the pallor can be many problem, many condition that associated with anemia or pallor. Sorry. So for the most important one is anemia, as you know. But apart from the anemia, you must rule out other causes. For example, decreased tendency of skin to pigment, and then alteration of consistency of subcutaneous tissue. And for example, edema, hypothyroidism, and last but not least is decreased perfusion of the cutaneous. So this is quite common, like hypotension and vasoconstriction. So this may cause the pallor in this patient. So when you approach this patient, you must exclude the this condition to lead your diagnosis to anemia. So if you confirm it is anemia or exclude other causes, so you can investigate or proceed further with your approach. So next is about the anemia. So let's talk about the anemia. So I think you know about the anemia. What is the definition of anemia? So by definition, the anemia, for introduction, is definition of anemia. So anemia is defined as hemoglobin or hematocrit. So two, hemoglobin or also hematocrit. That is 2 standard deviation below the mean for age and also the gender. So can be hemoglobin and also hematocrit level. So this is the definition. So anemia may be defined as a reduction of RBC mass, or we know as hematocrit, and also the hemoglobin itself. So anemia is, the common presentation that affect the children about 20%. So hemoglobin may have variant by age. also gender and also race. So for example, in this neonate, the cutoff is 14, and for up to 12 months, 10, less than 10. So this is cut off for anemia. And for like this patient, 4 years old, so the cut off is 11. And as you grow older, the cut off is higher. Like in female adult is about 12, the cut off, and the male is slightly higher, which is 13. So this is based on up to date. Next. So what is hemoglobin? So as a refresher, hemoglobin is a protein. Hemoglobin is a protein, not a red blood cell. Hemoglobin is a protein in the red blood cell that carries oxygen. So what carries oxygen is hemoglobin, that which is specifically attached to the heme, and also the heme at the center of the hemoglobin. So in the RBC have four hemoglobin or protein in one RBC. So that is hemoglobin. So next. So it is important to remember that hemoglobin is varies by age, also the gender. And there is no absolute cut-off value that define anemia actually. But in this table, as you can see, I take it from the PBS protocol, given the normal range or easier to approach the patient or to classify the patient, whether it is anemia or normal. So it varies based on age. So you need to remember that. So there is no cut-off point. It depends on the age, also the gender, and also sometimes the race. So okay. So how anemia is classified? So actually the classification is made to make diagnosis to be more to be more easier or more systematic. So generally the anemia can be classified into acute and also chronic. So acute is acute lah. Chronic more like a chronic disease, so more longer duration or chronic blood loss. So by pathogenesis can be the widely used is the based on pathogenesis. Pathogenesis either increased destruction or hemolysis, blood loss, and also the third one is decreased production, such as in leukemia or any iron deficiency. So this is based on pathogenesis. So we can classify also. Next is, I think this is quite familiar lah. Size also based on lab investigation, based on hemoglobin. So hypochromic, or normocytic, normochromic, and also third one is macrocytic. So hypo, normo, and also macro. So this classification is to make us more systematic lah. Next. Okay, this is I take from the sunflower. So I think you can refer it later. So basically impact red blood cell production, increase destruction such as hemolysis. So have a different differential. You can see in the right the orange box. And then the third one is blood loss. Blood loss such as in GI loss, macrodifluculum, and also VWD. Okay, so this is about the pathogenesis. So the next is okay, this is important one is because the classification of anemia usually we classify into this lab investigation. So based on hemoglobin. So microcytic, normocytic, and also macrocytic. So under microcytic, the common you must remember this at least four. So firstly is IDA. Second is thalassemia, either beta or alpha. So and then sideroblastic anemia, and also the anemia of chronic disease. So usually anemia and chronic disease is manifest by the normocytic, but in severe case, it also can be microcytic. You must remember that. So for normocytic, like I mentioned earlier, chronic disease. So usually chronic disease is normocytic. And then can be renal disease, marrow failure, or also hypothyroid. And for macrocytic or big cell is megaloblastic anemia, either by folate or B12 deficiency, and hemolytic. So hemolytic anemia can be normocytic or macrocytic. So you must remember that also. Hemolytic usually, as you know, I think you remember the hemolytic is usually normocytic, right? So you must remember that hemolytic anemia can be macrocytic as well. So also liver disease, hypothyroid, and myelodysplasia. So can be overlap. So next. So as any disease, history is the most important clinical approach, to establish the diagnosis. So we need to obtain a thorough or relevant history based on presentation of the patient. There is no shortcut for diagnosis. So for this patient, we must take a thorough history. So firstly, we ask about the anemia symptom. So at the onset, the severity, duration, or how the patient noticed or the parent noticed, and the severity based on either symptoms. So any lethargy, pale, irritability, this is the anemic symptom lah. So if we acute or severe, patient can have headache, vision blurriness, and also palpitation, dizziness, and fainting. So all anemic symptom you must obtain lah. Important to ask the patient. So also anemic symptom also we must ask for diagnosis and also to assess the severity. If the severe, the patient will come with dizziness or tachycardia, so indicate severe anemia. So if the patient mild anemia, so usually it's symptomatic. And then we must ask about the symptoms of hemolysis, such as urine color, scleral iterus, or jaundice. Urine color as dark color, brown color in the hemolysis. So also the bleeding symptom. And for bleeding tendency, for girl, we ask about the menstrual history, if applicable lah. For this patient, only 4 years old, so not applicable. Okay, so specific symptom, fever to indicate infection, and also abdominal enlargement, lymphadenopathy to rule out other chronic disease, and also the malignancy. So this is question that you need to ask. So next is the other history. So other history is also important. So ask about the past medical history, drug history, birth history, developmental history, family history, and also social history. So you can read. So every history is important. I list here, like past medical, drug history, so family history, or also the social and family history. So okay, next. And for usually for the children, we ask about the nutritional history or diet history. So it is important to rule out the dietary causes, such as in iron deficiency. So you need to ask about the nutritional, also dietary. So if the patient not consume enough vegetable or meat, so may lead to iron deficiency. And if infant consume formula milk and inadequate feeding, so this may lead to deficiency. So the evaluation of the child with anemia begins with a thorough history, the degree of symptom, past medical history, family history, dietary history, and also developmental history. So this history is you need to ask. Okay. So okay, do you like ice? I think all of you like ice. So anyone of you doesn't like ice? So I like ice here is ice cube. So not other ice. So some people with anemia may crave ice. This is interesting fact that some people with anemia may crave ice as a result of iron deficiency. One study proposed that this is because ice give people with anemia a mental boost. So this is you know as pica. So pica is abnormal apa? Selera. So this in IDA, the patient will have the tendency to eat the ice because can give the mental boost. Okay, just a fact. Okay. So apart from the history, so we must proceed to the examination. So why is important for us to examine the patient? Because based on history, we can proceed to the physical examination to look for any important clue for our diagnosis or for our diagnosis. So also to assess the condition of the patient. So if they're severe, we must exclude the acute condition. So physical examination, as usual, we go through the general first. Any thalassemic phase such as frontal bossing like in the picture, prominent malar and also maxillary bone. So also we need to assess the alertness on consciousness and hand, eye, also mouth for any angular stomatitis, head and neck for any lymph node enlargement, also tonsil. And then not forget the vital sign is for acute condition, tachycardia, tachypnea, skin, cardiovascular, abdomen, neuro for peripheral neuropathy in such as in B12 deficiency. Okay, so this you need to examine this patient. So next. Oh, sorry. This is for vital sign also neuro. So next. So I list the physical examination clues that specific to several disease. I think you can read later in the skin, Fanconi anemia, but it is rare. Fanconi anemia, carotenemia, jaundice, ulcer. Then next. Face, like I mentioned earlier, for thalassemia face, frontal bossing. And then for eye, so many clues that we can get from the eye. Okay, next. Mouth and chest, hand, and also spleen. Spleen for any enlargement like leukemia, lymphoma, and also acute infection. So you can look at the picture and also you can read later. Glossitis, angular stomatitis, cholinicia, esophageal. This is sign in the IDA, iron deficiency. Okay, next. So also this approach can be, we can use presence of hepatosplenomegaly, yes or no. If there is hepatosplenomegaly, we can suspect malignancy, chronic hemolytic anemia, chronic infection. So if no, other diagnosis must be suspected lah. IDA, so usually no hepatosplenomegaly, acute blood loss, so drug induced. So next. So continue about the child just now. So she presented to her pediatrician because of parental concern of pallor and also fatigue. So other history is remarkable except on dietary history, it was discovered that she was a picky eater, in which she avoid food like meat and also vegetable. She like to consume cow's meat about 20 apa oz per day. So about 25. Quite a lot, right? So her physical examination was remarkable aside from palo. So I think from this at this stage, you already have a quite clear diagnosis. So or several diagnosis. So I think so let's proceed to the investigation for this patient or for general approach. So for investigation for anemia, for example in this patient, we must start with the investigation which is blood. So I provide you algorithm. So let's look this first. So for FBC, we look at the HB level, RBC number of blood cell, and then we proceed with blood smear to look for any hypochromic or size or any shape, abnormal shape, and liver function to look for any bilirubin in the hemolytic anemia, and proceed with the iron status. Yes, doctor.
Anything in the FBC that you can see other than HB and number of
I think I will proceed later about the FBC.
Okay, all right, fine. Okay, we'll wait. Okay, all right.
Okay, so and then for hemoglobin hematopoiesis, also we do in the thalassemia, for example. So next is about the FBC. So what we want to look at the FBC. So next. So what to look in the FBC? So the most important one is hemoglobin. So hemoglobin is to diagnose the anemia, we must look at the hemoglobin. So if the cutoff is less than cutoff point, for example 11 or 12, so it is anemia lah. So and then we look at the MCV and also MCH, also MHCH. Other one. So this important to classify into hypochromic, normochromic, and also macrocytic. And also the RDW. RDW is red cell distribution width. So it's also important. So such as in the IDA is high in the RDW, because RDW it show the size, variability of RBC size. So REW show the variability of RBC size, which means that if the in the IDA hypochromic, right? Hypochromic kecil kan. So if the general size of the RBC is what varies or small and large, so multiple shape or size, so it leads to high REW. So it shows the variability of the RBC size. So so it's important to not the RDW. We can differentiate between IDA or also thalassemia. I will discuss later about that. So for reticulocyte sign, also important to indicate hemolysis, also blood loss, which is increase in the reticulocyte. Also white blood cell indicate infection, thrombocytopenia, and also pancytopenia in the FBC. All decrease pancytopenia. So that's important. So this
any calculation you can do.
A calculation for FBC. Maser index.
Yes. Are you going to go about Maser index?
Yes, after this. I think I will explain a little bit after this. So let's take a look the algorithm first. So quite small, so I'm sorry. So so this algorithm is I get from the up to date, quite comprehensive algorithm. So next is I will zoom in a bit. So if you use the phone, you can zoom a bit. So start with low hemoglobin. At the top is low hemoglobin. So if the patient confirm is low hemoglobin below the cutoff, and then if yes, we see if other cell line affected, such as in platelet or also white cell. So if other line not affected, you proceed with no. So if no, we look at the MCV. So MCV is important after HB. So we either the MCV is low, normal, and also high. So if low, the diagnosis is like iron deficiency, thalassemia, like I explained before. If ni microcytic lah, microcytic. So if normal MCV, normal CT. If high MCV, macrocytic. So I think you clear about that. So under the normal CT, at the middle, normal CT. So we look at the reticulocyte. So whether the reticulocyte is normal or high. So so the high MCV, so for macrocytic. So let's proceed to the normal CT first. Normal CT. So low MCV, macrocytic lah. So normal CT. So normal CT can be divided into low or normal reticulocyte and also high reticulocyte. So if high reticulocyte, the causes is hemorrhage. Only one, hemorrhage. Why hemorrhage? Because hemorrhage will lead to reticulocyte. Our body try to compensate or to produce a lot of RBC. So reticulocyte will be increased in the hemorrhage or acute blood loss. So if the normal or low reticulocyte, the diagnosis or the causes is such as the hemolytic anemia, infection, like in the list. So we proceed by the this algorithm accordingly. So at the right, if the patient is the lab investigation show the macro CT, we must proceed with the any drugs taken by the patient. So the patient may have the deficiency of B12 also folate. Also can be immune hemolytic anemia, like I mentioned earlier, can be macrocytic, right? So hemolytic anemia can be normal CT, also macrocytic, and several other causes. So we proceed to the investigation accordingly. We not do all the investigation. We must proceed with this algorithm to proceed the other investigation. So let's back balik. Okay. If the investigation show yes at the top, other cell line affected. If other cell line affected, such as in thrombocytopenia ke white cell, pancytopenia, we proceed with other algorithm. I will show you later. If the other cell line, such as platelet and also the white cell, we proceed to other algorithm. This is for the MCV, and the other cell line is normal. Can you understand? So I think this algorithm is important to remember. So all of you need to understand, also remember this algorithm. Okay, next. Okay, this is I provide you a table to differentiate between IDA, thalassemia, and also anemia chronic disease. So based on hemoglobin, as you can see in the table, hemoglobin is also all decrease. Anemia, right? So all decrease hemoglobin, and also the MCV all decrease, microcytic, and of course ACD or chronic disease can be normal, right? So RDW, I said before, increase in IDA because the cell is the cell size and also shape is varies. So RDW is will be increased, but in the thalassemia will be minimally increased or normal, and also for the ACD normal increase. For RBC decrease in IDA, and then normal in ACD. So and then important investigation for IDA is serum ferritin. So serum ferritin indicate the storage of the iron. So if the storage of iron is decreased, so it may indicate the IDA, of course. So if normal, most likely thalassemia, and increase in chronic disease, because the seroferritin is one of the acute phase reactant. If there is inflammation, so this ferritin will be increased, such as in chronic inflammation. So that's why increase in the anemia and chronic disease. So TIBC increase in the IDA. Also we also look the transferrin saturation. So this I mentioned is among the important parameter in the investigation or lab investigation. So next is I think you know about the Maser index. So Maser index we use to differentiate between IDA and also thalassemia. So we divide the MCV level, also divide by RBC count. If the value is more than IDA, more than 13, so it is most likely IDA the causes. So if the less thalassemia, less than 13, the cutoff is 13. So this is about the Maser index. You need to remember that. So I think you know. So let's proceed. So I think this is to ease you to understand. Same like I said before, RDW, you need to remember by this time, RDW normal or elevated. So if the elevated RDW, most likely is IDA. So you proceed with ferritin level. So ferritin level is high or low, low, most likely IDA. If normal or low, normal, it is thalassemia, favor thalassemia. And then you can read the difference between the IDA and also ACD. Okay, next. I think, okay, you can read this as well. Okay, this is other algorithm. So if the other cell line are affected, like in the box is in the red. So if the other line is affected, such as thrombocytopenia or neutropenia, so we must proceed with accordingly lah. So pancytopenia may indicate leukemia, aplastic anemia, hypersplenism. So anemia and low platelet may indicate other causes, SUS, TTP, DIC, also Evans syndrome. And you can read further. So the key here is you must proceed with the investigation or further investigation with according to this algorithm. You know, do all investigation. So I think that's about the algorithm. Next. So in the peripheral hypochromic, you can see the pencil shape in the arrow, normal. So normal like either left side, right side is in the IDA. For example, IDA, there is hypochromic, right? Hypochromic, and my hypochromic means the color, and the microcity means the size. So that is also the pencil shape, which is mark of the IDA, pencil shape RBC. Next. This is based on blood smear. So in the thalassemia, beta thalassemia, we can see the teardrop, and also target cell. Yes, target cell also teardrop. Target cell like memanah arrow, target cell, and also teardrop. So this is the finding in the thalassemia. Next. So I think you can read later about the B12. Basically, B12 and also folate. You must remember usually the difference in between these two is anemia due to beta pula. B12 deficiency usually with patient with present with peripheral neuropathy or have neurologic abnormality. But in the folate, patient doesn't have any neurologic abnormality. So that's a difference between these two. So both are due to the deficiency. So next. So you can read the causes like in the right side, vitamin B, malabsorption, folate, usually also the intake and increased demand, malabsorption, and also drugs that may cause the folate deficiency. So like I said before, neurologic finding only in B12. So loss of position, ataxia, psychomotor retardation, also seizure. Next. Okay, this is macrocytic. So macrocytic means big cell. So as you can see, the RBC is as you can see the purple one is the white blood cell. So the RBC is similar size, almost similar size to the white cell. So this is quite big cell lah. So in the second picture is so hyper segmented neutrophil. This is pathognomonic for macrocytic. B12 macrocytic. So usually the neutrophil only have 3 to 5 segment. If the more than 5, like in this picture, show the macrocytic. So next. So let's proceed to the management. So usually in acute setting, we resusc if the resusc by ABC lah, airway, breathing, circulation. This is just for principal management. So we monitor the blood pressure, vital sign, urine output, CVP until the patient stable. So we must resusc the patient if the in acute setting such as in blood loss or any shock, any shock. So then further management depends on the most likely causes. So we know, right? We investigate. We must have the diagnosis at this point. So next. So for definitive based on underlying causes. So if IDA, we provide nutritional counseling, give oral iron medication, and if indicated, but rarely indicated, is blood transfusion for child. And if spherocytosis, folate supplement, also splenectomy if indicated. If thalassemia, we provide blood transfusion according to severity. If you can read further about the severity, if major or minor, different cut-off of the indication for blood transfusion. Iron chelating therapy, splenectomy, diet and also supplement, and BMT, bone marrow transplantation. Next. So I think okay, next. Okay, I think that's all about the management. So I think further slide you can read detail about the, for example, IDA in this patient was IDA, right? So you can read further the management, just management. Next. Okay, just management. Okay. So I provide for thalassemia as well, because thalassemia is common. So I provide detail about the management. This is based on PBS protocol. So I think that's all from me. So any question from you?
Okay, before anyone asks question, I just want to remind you all, differentiation between IDA and thalassemia is among the favorite questions in exam as well. I think thalassemia has come out in thalassemia will definitely come out in your exam. What I can say is in your block exam, probably you guys are still using the old curriculum. So the cases will be what cases that is in the ward. So sometimes you won't usually get thalassemia patients in the ward, but you will definitely get thalassemia patients in for professional exam. You will definitely. And if you guys are going for apa nama, we still haven't we are still not clear yet how your end block exam is going to go. But if it's patients that we are going to call, among the easiest patients to call is actually thalassemia patients, because we have the list. So you guys need to know how to manage, how to approach patients with anemia, with pallor, how to differentiate whether it's thalassemia, whether it's malignancy, whether it is iron deficiency anemia, and the management as well. And then remember, thalassemia is one disease that I expect you to know in great detail. Thalassemia is one of the diseases that I expect you to know in great detail. It has so many complications, head to toe complication, and I expect you to know everything, thalassemia. Okay? All right, fine. Proceed.
Doctor, sorry. Is it true that thalassemia is uncommon nowadays because of the early intervention?
I wouldn't say uncommon. I would say less common nowadays, because how we approach thalassemia. I think because our care for thalassemia is getting much better. We are using a hypertransfusion regime rather than the previously we transfuse patient less because of risk of infection and so on and so forth. But now we transfuse much earlier. We have higher level of the hemoglobin that we aim. So less, it's getting less and less common. So most of the thalassemia patients that we'll see nowadays, they don't have the typical thalassemia phases anymore. Okay, all right. Okay, proceed.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Okay, I'm going to proceed with another topics of today's discussions. So it is about child with easy bruising. My name is Abdullah. Today I don't open the video because it's going to interfere with my internet connection. Okay, let's proceed. Okay, now before there's something we should know the definition first. So about bruise. Okay, so definition of bruise or ecchymosis, it is a collection of blood beneath the skin resulting from extravasation of blood from surrounding vessels. Okay, that is bruise. While easy bruising, it is a bruising without a history of trauma, or it is a bruising after minor trauma that would not have caused bruising in the past. Whereas significant easy bruising is defined as 5 or more bruises greater than 1 centimeter in diameter. Okay, so that's a brief introduction about the definition of bruise. Okay, now let's recap a bit about hemostasis. It is not a detailed explanation, but I hope it's going to give you ideas or some recalls, a blast from the past. So, okay, so it's I provided a diagram here. It is a general. On your left, it is a general step of clotting, and on your right side, it is a fibrin synthesis cascade. Okay, so as in general, if you have a cut or your blood vessel is severed, so your blood and blood components will leak out of the vessel, right? So the next action will come in play is vascular spasm. Vascular spasm function in a way to prevent further blood loss. So action from the small muscle of the vessel, spasm of the small muscle of the vessels will prevent further blood loss. And then a key player in the hemostasis, which is a platelet. So platelets are going to be attracted and alarmed to the site of injury. And then the platelet itself will then be activated and then will form and then will adhere to the site of injury, will form a clot there. Then from the platelet there, it will induce other platelets to be activated and then plug in and form platelet plug as well. After that, in coagulations, fibrinogen was then converted to fibrins in which it will form a mesh that will trap more and more platelets and erythrocytes, and will soon produce a clot. So at this point of time, the blood loss can be stopped. Okay, on your right side, you can see the fibrin synthesis cascade. So it is actually a cascade, a pathway of the factors that in actions. Okay, it is consisting of the intrinsic pathway, extrinsic pathway, and finally we become a final common pathway. All this is in the end it will produce fibrin to help in the blood loss action. Okay, so that's a brief about the hemostasis. And now let's dive into our topic. So when a patient come with the problem of easy bruising, we ought to have a differential diagnosis of our own. And then over here is a diagram which show you the etiology or the causes of bleeding that a patient might have that causes him or her to have easy bruising. So it can be divided into hematologic and vascular non-hematologic. Under hematology, it can further divide it into thrombocytopenia, which is a problem with the platelet, and then coagulopathy with the coagulation cascade problems. So if you can see, there are a lot of possible diagnoses that can happen to a patient, and it is our responsibility to get the thorough history, perform physical examination, and do relevant investigation to identify what is the main patient's problems. So you can have a look for the division simulator. It's the same both goes for hematologic and vascular non-hematologic. Both of them have their own history and physical examinations, clinical assessment that we need to do. Okay, so talking about history taking, so we have to give our attention to the age of the patient presented, because it might give a clue whether the condition itself is a congenital or it is an acquired. And then we ought to have we need to take heed of this site of bleeding, whether it is just superficial, involves mucocutaneous, or it is deep, involve any joints, any effusion of joints. So we need to ask the history, we need to ask the locations, disability, and so on. So, and then the degree of trauma. So we need to ask patients if the trauma is whether the bleeding or bruising is spontaneous, or it is a significant force required to produce the bleeding. And then drug history such as NSAID, anticoagulants, antiplatelet, glucocorticoids, dietary history, any deficiency of dietary protein, vitamin C, and vitamin K. And also we need to ask patient's family history, because some of the condition, as was mentioned before, is congenital. So any family members might have the same episodes or same bruising or bleeding as the patient has right now. So this is the history taking in general. The next one is about physical examination. Okay, so in physical examination, we ought to pay attention for detailed mucocutaneous exam for PTK, purpura, ecchymosis. Don't worry, I will show you the picture of comparison of each of the PTK, purpura, ecchymosis I mentioned. And then we check for any sign of hepatosplenomegaly. We examine the joint for the range of motion and also presence of effusions. And if we are suspicious of non-accidental injury or abuse, we might as well offer access for child's motor developmental milestone. In short, we need to perform in every way possible to help us to attain the diagnosis in the end. Okay. So this is the picture that I've been talking. So as you can see, there's bruise, petechiae. Petechiae is a non-blanching lesion, less than 2 mm in size or pinhead size. And purpura is the coalesce of the petechiae, a group of adjoining petechiae. And hematrosis, bleeding into joint space, where you can see swelling or effusion as at the in this picture at the patient's knee joint. Okay, next one is about investigations for easy bruising patients. So in investigations, we're going to do full blood counts, in which we are going to look at the differential counts, particularly looking at the platelet counts. Patients, most of the patients going to present with thrombocytopenia. And then another option is peripheral blood filler, where we can see abnormal platelet shape. Sometimes platelet is big, it's called megakaryocytes. And then coagulation profile, where it consists of PT and APTT. And then in investigation, we could also screen or do investigation for specific factors for specific condition that we are thinking of. For example, in factor 8 in hemophilia A, or von Willebrand disease patients, or factor 9 in hemophilia B, and then so on and so forth. Okay, hope you guys can still follow me. Okay, the next one is so basically this algorithm which I obtained from a journal from the MD. So it is an algorithm that shows a simple approach to investigation of easy bruising. So the question comes with an easy bruising. So we divide it first. Whether if it is the bruising is mainly focused on leg or no petechiae, purpura, mucosal hemorrhage, and no family history, then we might consider just to observe without further investigation in this kind of patient. But in another group of patients where we see a typical pattern of bruising with or without presence of petechiae, purpura, or mucosal hemorrhage, then we ought to do FBC and clotting screen. Okay. In this investigation, we're going to look for, like I mentioned before, the platelets, the platelet counts, the abnormal, any clotting deficiencies, or if the patient is normal. In the case, if the patient is normal, then we inquire about patients, did he consume any drugs or has collagen vascular disorders, any history of platelet function disorders, and so on and so forth. And if the condition still persists, then we refer to a specialist. Okay, that's for if there is normal FBC and screen. But if there are isolated thrombocytopenia, we can think of ITP or immune thrombocytopenia, purpura. And then in case of abnormal clotting screen, okay, I provide you the table here. Okay, in abnormalities of clotting screen investigation, so there are 3 mainly that we're looking for. In the first one, in accelerated prolongation of PT, prolonging time. The cause we can think of is vitamin K deficiency in hemorrhagic disease newborn or malabsorption or liver failure or any consumption of any usage of warfarin. And the second one is an accelerated prolongation of APTT. So it can be caused by von Willebrand disease, coagulation factors deficiency, lupus anticoagulant, or can be due to use of heparin. And if the third one is if both abnormalities present, combined abnormalities, then it can point out to it can be liver failure, vitamin K deficiency, disseminated intestinal coagulation, or other rare causes, fibrinogenemia or this fibrinogenemia. Okay, so that's among the cause from the result of investigation that we have done to our patients. Okay, so at this point we are going to look at a few, actually three common diseases that we encounter in our clinical practice. Okay, so the first one is regarding immune thrombocytopenic purpura. Okay, so I'm just going to run through these three diseases as for recap my introductions and to know a little bit more of our discussion today. So the first one, ITP, it is a benign self-limited presenting with isolated thrombocytopenia, which is less than 100 or 10 to the power of 9 per liter in the absence of underlying cause. So in the absence of underlying cause, there need to be interpretation. So it can be categorized into three categories. The first one is newly diagnosed ITP, which is an ITP within 3 months from diagnosis. The second one is persistent ITP, which is ITP lasting between 3 and 12 months from the initial diagnosis. And the third one is chronic ITP, it's an ITP lasting for more than 12 months. So that's the category of ITP. So about the clinical features, so ITP onset is usually abrupt or acute. It can sometimes have a history of preceding illness, preceding viral infections, such as Epstein-Barr virus, influenza, or any history of vaccinations, such as MMR vaccination. And then patient can present with mucocutaneous bleeding, such as petechiae, purpura, ecchymosis, epistaxis, gingival bleeds, GIT, GUT, or vaginal bleeds. So all of these components we must ask and verify during our history taking, including the symptom of intracranial hemorrhage, which can signal a life-threatening condition, in which patient with intracranial hemorrhage, he might have a headache, persistent vomiting, automatic status, or seizure, and focal neurological findings. So in for physical examination wise, we can patient should present, but we can hardly find any hepatosplenomegaly and lymphadenopathy. Okay, so for investigation of ITP, first, as usual, we're going to do full blood counts. We're going to look for differential count, specifically of the platelets. So in this case, it's going to be isolated thrombocytopenia. And then we can do peripheral blood film. It is normal apart from the platelet itself. It can be large or reduced in count, and no other abnormal cells. Bone marrow aspiration in ITP patient is not necessary. If an examiner, if a clinician confidence certain that the history, the physical examination, and investigation already point out to ITP. Okay, so for the management of ITP, most of the time ITP will remain spontaneously, and not all child requires hospitalizations. Often in certain cases only that we consider hospitalizations. For example, in patient with severe life-threatening bleeding, in patient who has intracranial hemorrhage, regardless of their platelet count. Another one is platelet count is less than 20 to 10 to the power of 9 actually, with evidence of bleeding, or less than 20 times 10 to the power of 9, but without bleeding, but the patient doesn't have any access to any healthcare. And then lack of confidence in home care. So all these conditions we can consider to hospitalize a patient with ITP. Then the advice we can give to patient with ITP conditions is that we can advise them to exercise precaution with physical activities, especially with small children, avoid contact sports, seek immediate medical attention if significant bleed is happening, and try to avoid aspirin and NSAID. Okay, and then treatment is
why avoid NSAID?
Because probably NSAID promotes more bleeding in patients.
Because NSAID affects platelet function.
Oh, okay, yeah.
So you already have low platelet. So if the remaining low platelet then affect the platelet function, then risk of bleeding is there, isn't it?
Yes. So NSAID is going to affect the platelet function. Okay, thank you. Okay, I'm going to proceed. Okay, so treatment is generally indicated in ITP patient if there is life-threatening bleeding episodes, regardless of platelet count, and the platelet count of less than 20 with universal bleeding, or platelet count with less than 10 with any bleeding. So this is a general indication for patient with ITP for treatment. So talking about treatment, among the choices of treatment that we have, we can give the first one is oral prednisolone of 2 milligram per kilogram per day for 14 days, then taper off over 5 days regardless of response. And then oral prednisolone for 4 milligram per kilogram per day for 3 to 4 days. Or we can give IV immunoglobulins 0.8 gram per kilogram per dose for single dose, but we round up to the nearest bottle to our station. So all of this that I've been talking about ITP is I refer to PITS protocol. You can maybe have a look at the protocol to have a clear insight of what I'm talking about. Okay, so this is basically the grades and going to be an algorithm of what I obtained from up to date. So in ITP, we can grade disability or bleeding symptom in children. So the grades are ranging from the grade 1 until grade 4, which translate to the bleeding severity. Okay, so grade 1, as you can see, is a minor or minimal until grade 4. It can be severe and it might extend up to life-threatening. So for each of these grade, it's going to be a different. It's going to be associated clinical symptom that going to accompany the grade itself. So this is a guideline that we can use to guide our treatment. Okay, I'm sorry if you cannot see clearly. Okay, but okay, so from the grade that we have grade our patients, then we can continue to consider our option for treatment. So it's actually the same as what it's kind of the same of what I'm talking in what I refer to in PITS protocol. The grade can be divided into two. The first one is grade 1 to grade 3, and the second one is grade 4. So I believe if you have time of this, you can have a look of what of the option that we're going to give to the patient, respective to their own severity, on bleeding severity. Okay, I'm done with the first in this. of ITP. The next one is about, the second disease is about hemophilia. Okay, so hemophilia is an off-X-linked recessive inheritance. But bear in mind, there are 30% patients that there is no family history, as it is a spontaneous new mutation. So it's extenders that don't be surprised that if the patient doesn't have any family history, perhaps. And then the most common hemophilia, there are two. As you all know, there are hemophilia A and hemophilia B. Hemophilia A is deficiency of factor 8, 85% of the cases, and hemophilia B deficiency of factor 9, 15% of the cases. Okay, so for clinical features, bleeding in the neonatal period is unusual. Bleeding usually present with a patient usually present with easy bruising when crawling and walking, usually at the age of 9 to 12 months. Hematrosis is a characteristic of hemophilia. Large joints are usually affected, such as the knee, the ankle, the elbow. One sign is swollen, painful joints. Those are the common signs. And then epistaxis, gum bleeding, and hematuria also can occur. And then we also need to inquire about any symptom of intracranial hemorrhage, because it can be life-threatening to patients. And then bleeding may also occur spontaneously or after trauma, operation, or dental procedures. Okay. Right. Next one, investigation in hemophilia. Okay, we do the first one is for blood counts. Is usually it is normal, prothrombin time normal, activated, but inactivated partial prothrombin time. It is usually prolonged, especially in moderate to severe hemophilia. Then, if it is prolonged in FATT test, then we're going to proceed with factor 8 and factor 9 assay. And then after we have done the assay test, then we can classify the hemophilia according to the factor level. So you can see in the table that I provide, the factor level, if it is less than 1%, it is a severe type of hemophilia. It can present with spontaneous bleeding, risk of intracranial hemorrhage. Whereas as for moderate and mild, they can present with bleeding that can occur only with trauma, surgery, or dental procedures. However, it depends on the clinical presentation at first before we perform the investigation. Okay, next one is about management. So it can be specific treatment and supportive. But we go to this supportive treatment first. We can give patient with hemophilia and anesthesia, especially to help them alleviate the pain during episode of hematosis. Observe dental care, immunizations, and then avoid contact sports, and avoid aspirin and SAID and IM injection, intramuscular injections. And this can promote risk of bleeding in patients. And then next one is treatment. We have also, the first one is prophylactic treatment, in which we can give patient the factors replacement, be it regular factors 8 or factor 9 replacement. Depends on the as the dose dimensions. And then during bleeding attacks, patient can be given recombinant factors according to severity. Then how much we should give patients, we can use the formula that I provided below. Calculated dose equal to percentage desired. Desired means rise in how much rise we need in factor 8 and factor 9. times the body weight of the patients times 0.5 or times 1.4. So this is for during main attack. Okay, so that's a brief about hemophilia. And then we go for the third one, the last common disease that I want to share with you today. Okay, so it is about bone Willebrand disease. It is actually caused by an deficiency or abnormal functions of bone Willebrand factors. It is an autosomal dominant condition. It's kind of most common inherited bleeding disorders. Okay, so bone Willebrand factors it serves two functions. The first one is acting as a bridge between epithelial collagen and platelets. And second one is binding and protecting circulating factor 8 from rapid clearance from circulations. So absence of or diminished bone Willebrand factors will have effects on these two main functions. Okay, so this is the classifications of bone Willebrand factors, bone Willebrand disease. There are three. Type 1, it is due to a quantitative reduction in bone Willebrand factors, proteins, both concentration and activity. And then type 2 is due to dysfunctional bone Willebrand factors. And then type 3 is due to absence or severely reduced bone Willebrand factors. So, patient with bone Willebrand disease can have the following clinical features. Severity of bleeding is variable. It's bleeding typically from mucous membrane, mouth or nose bleed, and menorrhagia. And then excess blood loss following trauma or surgery. Hematosis and muscle bleeding are rare, except in type 3. So these are among the clinical features in patient with bone Willebrand disease. So investigation that we can do, as usual, we can go for MBC, which is usually normal, or thrombocytopenia, and then MPTT, normal or prolonged, and then PT normal, factor 8 often reduced, and bone Willebrand factors antigen reduced. And then another kind of test, which is named histocity-induced platelet aggregation, which, or in short, it is RIPA. It is actually a test that measures the effectiveness or the integrity of the bone Willebrand factors. So, defective platelet function is signaled by a diminished aggregation with histocity. I am not sure whether this kind of test is usually done in patient with bone Willebrand disease, but I've read about it, and I reckon that I can share with you. Maybe if you have something, you can have a look at what this is actually about. Regarding is related to bone Willebrand disease. Okay. So the next one is the treatment for bone Willebrand disease. We should avoid NSAID and aspirin. Desmopressin is effective, especially in type 1 and some of type 2. And then we can also give patient anti-hemophilic factors or bone Willebrand factors complex known as HUMAT-P. HUMAT-P, which contain factor 8 and bone Willebrand factors. Okay, so this one we give for severe bleeding episodes, and it is the only effective treatment in type 3 patients. We can also consider giving cryoprecipitates and fresh frozen, but it is not recommended because most of them is not virally attenuated. And then we can also consider to give antifibrinolytics. For example, I wish system. It is a name for drugs named epsilon acid caproic something. But you can have a look for it later. It acts as an adjuvant treatment in oral bleeding. Okay, so this is the treatment for patient with bone Willebrand disease. Okay, so I hope you guys are still okay. I'm sorry if I go a bit fast, but if you have any question, you can ask. Maybe you can discuss.
I have a question. I would like to ask about why we have to avoid intramuscular injection again? Is it because of the tendency of bleeding?
Yes, I reckon so because in patient with bleeding disorders, if we try to poke or do intramuscular injection, it might cause the patient to have a hematoma or further, or worse, patient might have a risk of bleeding.
Then does that mean you have to avoid intravascular too?
Yes, if it is possible. Any treatment or any
Alright.
you can opt for other means.
And another thing is, if you do certain procedures that may cause bleeding, even though it's minimal, the issue is you may cause consumptive coagulopathy, consumptive thrombocytopenia. So I've had a patient before who was diagnosed with ITP. So and then the patient, because we did tell the parents, but we didn't say clearly to the teachers. So what happened was they did dental punya team datang sekolah patient tu, and then they did some dental procedure on the patient. So bleeding dia tak lama sangat, tapi what happened was consumptive thrombocytopenia, and then what happened? Patient developed cerebral intracranial bleeding, causing stroke on this patient. So this is one thing that you need to remember lah. So you don't just tell the father, tell the parents. You need to tell the school as well. Proper letter.
Doctor, is the meaning by consumptive
Consumptive because platelet dia dah lah sikit, but when you do certain procedures, when you do intramuscular injection, so platelet yang dah sikit tu digunakan untuk settle that bleeding, untuk stop that bleeding. So the risk is dah tak ada lah, the reduce lah, much more reduce lah the platelet. So sama juga dengan coagulation factors. So when you do certain procedures, so whatever coagulation factor yang dia ada tu is utilized, is consumed to stop that particular bleeding, and the result is consumptive coagulopathy, consumptive thrombocytopenia. Faham tak?
Okay, understood. Thank you, doctor. By the way, I just wanted to know the case that you just share. Kenapa bleeding tu boleh cause cerebral hemorrhage?
Bleeding doesn't cause cerebral hemorrhage. So
I mean that patient macam mana cerebral hemorrhage?
Because the platelet is too low. So bila platelet is too low, dia senang jadi bleeding lah, even with minimal. So it's just that because the platelet is too low.
No. Alright, thank you, doctor.
Doctor, sorry to add, is it because of the spontaneous hemorrhage?
We for that particular patient, we don't exactly know why. Tak ada, tapi there's no history of trauma lah. It could be because spontaneous, we don't know.
Okay, doctor, thank you. So I proceed with my presentation. So my name is Muhammad Azlan Izwan Mirazali. I will share with you about topic child with jaundice. Actually, for neonatal jaundice will be shared or presented by Hazika and the team. Okay, so next. All right. So this is my outline. Introduction, bilirubin metabolism. I hope you still remember. And it's important too. And then classification of the cause, approach, and the reference. Okay, next. Okay, jaundice. So patient come with jaundice. So what's jaundice? Jaundice, yeah, it's a yellowish discoloration of sclera, skin, and mucous membrane. You may not to salah. Okay, for this, you know the cartoon in the picture is Homer Simpson. Everybody in that cartoon all are yellow, and then for Trump, you may not be misinterpret. It is normal for Western people who have carotemia or lycopenia. So yeah, never mind about Trump. And then yeah, jaundice is a state of hyperbilirubinemia. All right, and then clinically detectable in pediatric protocol. It's mentioned that more than 85 micromole per liter, and then the child and adult about 34 to 51 is the range of values. However, it depends on environment lighting, and then clinical judgment. When for example, when bila kita tak pernah jumpa patient yang jaundice, so we wouldn't know that the patient is jaundice or not, or maybe we are just misjudge about their skin. So we must see patient actually. All right. Then bilirubin has two state, okay, unconjugated versus conjugated. Then it also can be divided into pre-hepatic, hepatic, and post-hepatic cause. So next. All right. So I hope you still remember about when RBC is broken down, either intravascularly or extravascularly. Basically, the globin will be broken down into constituent amino acid where will be recycled again. However, for him, they will be will be taken up by macrophage, reticular endothelial system, where he will be broken down into biliverdin, undergo oxidation, and then reduction into bilirubin. But this state, it is unconjugated, and then it's lipophilic in nature. That's why in in bilirubin encephalopathy, this bilirubin, unconjugated bilirubin, can pass through the blood-brain barrier because of the lipophilic in nature, and that's why they need albumin. Okay, albumin to be transported to the liver in the blood. So in the blood, they will undergo conjugation. So they are double conjugation by UDP glucuronil transferase until they will become conjugated bilirubin. Okay, so this one is more water soluble, and that's why when it later it will mix with the bile and be excreted into duodenum. In duodenum, there will be further by the enzyme glucuronidase enzyme of the bacteria in the gut will convert it from conjugated bilirubin into urobilinogen. In the terminal ileum, there will be enterohepatic circulation where reabsorb of 10% of it, urobilinogen, into the bloodstream. Okay, and the rest in the gut will be okay, in the gut they will be give the color of the stool. All right, in the urobilinogen in the bloodstream, half of it will be used recycled, and half of it will be passed in the urine as urobilin. Okay, next. So this is important because it has clinical etiology. So you see in the classification, jaundice can be classified into unconjugated and conjugated. And then in unconjugated is actually occurs in the side of prehepatic and hepatic, while conjugated mostly post-hepatic. Okay, then unconjugated should you must understand it should be divided into hemolysis and not hemolyzed cause. So for example, in positive cum test, the causes may because of ABO or resistance incompatibility, drug induced, and then could be negative cum test, G6PD. You must still need to remember G6PD, and then sickle cell anemia. And then RBC membrane defect include hereditary spherocytosis. Okay, For the non-hemolysis, can be due to Gilbert. I will discuss it about Gilbert after this. And then physiologic jaundice, according to Nelson textbook, it's mentioned that the breast milk jaundice causing it inhibit the bilirubin uptake in the hepatocyte. Okay, and Krieger-Najjar syndrome will be I will explain later on. Hypothyroidism, firstly, first hypothyroid itself, it can reduce the conjugation rate, and then it also leads to constipation, right? So it will increase the duration fecal material inside the gut. That's why enterohepatic circulation is increased. So bilirubin will be will be taken more. And then breast milk, okay, hypothyroid, then pyloric stenosis. Pyloric stenosis in Ashkoff textbook, if mentioned that it's only associated of a decreased enzymatic activity in the liver. It does not further elaborate about that further. And then internal hemorrhage. Okay, for conjugated, yeah, look at the obstructive. I will discuss, I will tell more about Alagille syndrome, and then biliary atresia. Biliary atresia in pediatric is, I think you must remember biliary atresia. Okay, the rest, okay. Choledocalcis, cholelithiasis. So these also are risk factor for jaundice in pediatrics. Okay, next. All right, so this is based on anatomical, pre-hepatic, hepatic cause, and then post-hepatic. So it's the same as before, just classification by anatomy. Okay, next. Okay, post-hepatic also, there is, okay, if you can see, there is intrahepatic cholestasis syndrome at the right side, okay, and then extrahepatic disease. So yeah, it's the, okay, I think you can read about the disease. Okay, next. Okay, Krieger-Najjar syndrome. There are two types of okay, there are two types in Krieger-Najjar. First, type 1 is both are autosomal recessive. So in type 1, there are complete absence of UDP glucuronine transferase. Okay, the complete absent means there are no enzyme to conjugation for conjugation. So we presented with unconjugated hyperbilirubinemia. So Krieger-Najjar syndrome is very rare. So it's hepatic jaundice cause. Okay, so how to diagnose is by liver biopsy and DNA analysis. So the treatment will include phototherapy until adulthood because of the risk of the bilirubin encephalopathy. And then the definitive treatment is liver transplant for Krieger-Najjar syndrome type 1. Okay, for type 2, there are still present of UDP glucuronidase transferase. So how to diagnose is phenobarbital challenge. I expect this phenobarbital challenge is test is done in the clinical setting. Yes, betul tak doktor? Kita masih gunakan phenobarbital test? Oh no.
Yes, we can do. But
Okay.
the thing is, this disease is extremely rare.
Oh,
Very,
okay.
very rare.
All right.
I've not done myself. I've not seen any patient with Krieger-Najjar.
Oh, okay. So phenobarbital challenge is like an enzyme inducer. It just induce the UDP glucuronidase transferase. Then yeah. Okay, so presented with unconjugated hyperbilirubinemia and the risk is unusual. Next. So the role of phytotherapy, as I mentioned in Krieger-Najjar. So the role of phototherapy is important until adulthood because of the risk of bilirubin encephalopathy. So how does phototherapy act is by, or is the known is photoisomerization. It will isomerize the unconjugated bilirubin into two isomers, either structural and configurational form. So these two forms are more water soluble. That's why it can be excreted into the into feces or urine. But make sure prior to the phototherapy, make sure the child is able to pass urine or bowel opening, so that the excess bilirubin can be removed lah. Kalau tak, macam mana dia nak remove kan? So make sure the child can pass urine and bowel opening. Alright, next. So Crigler-Najjar syndrome dengan Gilbert syndrome is more like the same because it involves UDP glucuronidase. However, Gilbert syndrome is milder compared to Crigler-Najjar. So all the parameters it is milder compared to Crigler-Najjar. Okay. Next is the same. Okay. For biliary atresia.
Oh ya. Ayah ada panel dah. Kakak ada kelas.
Okay. Alright. So then biliary atresia, I think is the most important you guys need to know, because one of the diagnosis of prolonged jaundice. Prolonged jaundice is more than 14 days of life. Okay. Okay. So biliary atresia, we presented with conjugated hyperbilirubinemia, obstructive jaundice. And then what is biliary atresia is the absence of part or entire biliary tree. There are 4 subtypes, 1, 2A, 2B and 3. Okay. So kalau tengok 1, the CBD is obliterated, 2, common hepatic duct is obliterated, and 2B is both common hepatic duct, common bile duct is obliterated. And then 3, all are entirely obliterated. Okay, so diagnosis from the pediatric protocol is mentioned by ultrasound. Ultrasound, we do ultrasound of hepatobiliary system, and we can see there is dilated intrahepatic bile duct because of the bile there is no outflow, right? So there is no outflow, so it will congest the bile duct, congest the liver, and then there is no absent, and there is absent or contracted gallbladder. And then we can do liver function test to diagnose. Usually gamma glutamate transferase will be elevated. So it is what? It is sign of obstructive jaundice. And then together you need to check coagulation profile. 2, 7, 9, 11 is fat soluble vitamin, right? Okay, HIDA scan. What is HIDA scan? It's a nuclear imaging whereby you will inject the contrast. Inject the what? Sorry, wait. HIDA scan is common done. The name is hepatobiliary hemodiastatic acid scan. Okay, whatever lah. Nama panjang. So it's often done to evaluate the condition of the liver, bile, or gallbladder. So in biliary atresia is very helpful because when you inject the contrast and then you see there is no outflow into the gut, so it means you can make a diagnosis of biliary atresia. I think this is most important. And then you can proceed with liver biopsy. Okay, because why we do liver biopsy even in biliary atresia? Because in the liver itself there is atresia. There is it's not only affect the biliary tree, but also affect the biliary tree in the liver itself. So we do the liver biopsy to confirm, and then we proceed. If HIDA scan suggestive of biliary atresia, we do cassette procedure as soon as possible, because cassette procedure we do early as possible because it's good prognosis. Kalau lambat nanti low prognosis lah. So cassette procedure is next. Okay, so the most important is type 3 type 3 tadi. So kasar procedure is hepatoportoenterostomy. So how it's done is we anastomose the ileum, okay, the ileum into portal hepatis, and then the duodenum, the end of duodenum, we do end-to-side ileum, do end-to-side anastomosis. So yeah, hepatoportoenterostomy for biliary atresia, and the proper treatment is liver biopsy. The proper treatment is liver transplantation. Okay. All right. Next. I'm sorry, it's quite a bit dry. Okay, Dubin Johnson, MRP2 protein, which mutated. Okay, what is MRP2 protein? It's the protein that secrete the conjugated bilirubin into bile duct. So how do we diagnose? Is by bromsulfalin BSP. This is an IV coles. We inject into IV. Okay, so bromsulfalin will enter the liver as a substrate for conjugation. So when there is no, imagine there is conjugation happening, but there is no outflow. There is no protein there is no MRP2 protein to secrete into the bile duct. So this bromsulfalin conjugated bilirubin will enter the enterohepatic, will enter the bloodstream. So raised in serum 90 minutes post infusion. So bromsulfalin. Okay. Next. So allergy syndrome. Allergy syndrome, there is one case. Cuba tengok gambar terus. Okay, there is one case in IIMC, as I remember. There is one case of allergy syndrome. Next. So look at the picture. So from the picture, so it's a genetic syndrome. Allergy syndrome is a mutation. It's a microdeletion of chromosome 20, P12. All right. So what you can see from this picture, there is broad forehead, long nose, and then the pupillary distant. The eyes is quite distant. Okay, and then their maxilla is underdeveloped. Yeah, and then the fatter mnemonic is butterfly vertebrae. Doctor, allergy syndrome, there is one case in IMC, right?
Yes.
Yeah.
Definitely. Very
Okay.
rare. I think we only have less than 5 patients in whole Malaysia.
Okay. And one is in IMC. So okay. Okay, next. So fatter mnemonic is butterfly. Okay, butterfly vertebrae. Okay, for the complication, kernicterus. Kernicterus is actually, for your information, kernicterus is postmortem diagnosis. Postmortem diagnosis. Okay, so we use bilirubin encephalopathy. Okay, so I think you know what happened. Unconjugated is the culprit is unconjugated bilirubin that passed the blood-brain barrier. Okay, so when we do postmortem, we will see yellowish staining in the basal ganglia and brainstem nuclei. All right, and then we need to aware not to let unconjugated bilirubin more than 340 or more than 20 milligram per deciliter. So because kernicterus is permanent. And then other risk factor is like sepsis, asphyxia, disease PD, hemolytic disease. So this can cause bilirubin encephalopathy. And from so the other risk factor I get from Nelson Essentials, for example, like temperature instability, extreme lethargy, serum albumin. Why serum albumin? Because we know the function of albumin, right? To bind with unconjugated. So still need to consider the cost. Okay, next. kernicterus in older child and adult is uncommon. Okay, not as common as in younger child because the liver capability for conjugation is increased, and then blood-brain barrier is more mature. Okay, then next. All right. Okay. Phototherapy in older children, is it done? No, because phototherapy is only given below 14 days of life. Okay, for the term babies, for preterm until 21 days. We this from previous say my senior say, because the fact that blood-brain barrier will mature, regardless if the patient, if the babies has hyperbilirubinemia more than 14 days, we still we can stop phototherapy because due to the fact that BBB will be mature, and then the risk of kernicterus is reduced. Okay, and then if we want to give phototherapy for babies less than 14 days, we give at night because we want to avoid interference of their daily activities. We want them to grow, right, to play in the morning. Okay, next. Okay, so I will not touch more so much about the symptom, the physical examination. However, what you need to know is the gist is you need to differentiate obstructive jaundice dengan non-obstructive jaundice. Okay, so obstructive jaundice, the symptom could be jaundice, pruritus, pale colored stool, and then dark colored urine. Okay, and again, you need get all the question, all the physical examination you want to check. So yeah, this is systemic approach. So okay, sorry. So in history and physical examination, when you sell your provision diagnosis, rule out the other causes, and then to rule out any complication. Okay. So I'm not touch more about the symptom and also physical examination. Okay, next. Next. Okay, then investigation. A bit detail about investigation. You need to differentiate, is it direct or indirect, conjugated or unconjugated, okay, by serum bilirubin and liver function test. So you need to order that, of course. How to determine conjugated and unconjugated is direct bilirubin more than 15% of total bilirubin. Okay. So if the criteria is not met, so the hyperbilirubinemia is classified as unconjugated. So this I took from pediatric protocol. Okay, next. So of course, you need to do unconjugated bilirubin workout because unconjugated can be caused by hemolysis and non-hemolytic, right? Hemolytic cause. So you need to differentiate when you cross unconjugated bilirubin is high. Okay. So when hemolytic causes, reticulocyte will hide. As compared to non-hemolytic cause, reticulocyte will become normal. Okay, so direct test is important. Full blood picture. You do have HbA electrophoresis, and then fluorescent test and enzyme assay for G6PD, and osmotic fragility test for hereditary spherocytosis. So where osmotic fragility test by doing to dilute in serial dilution, if the RBC lies, so it's positive osmotic fragility test. Okay, and then reticulocyte when normal, you need to do thyroid function test because thyroid function test is one of the important cause of prolonged jaundice. If negative, you must rule out breast milk, physiological jaundice, Kricke-Najjar, or Gilbert syndrome. Pyloric stenosis, you do ultrasound of the stomach where, as far as remember, more than 4 millimeter or more, the thickness of the pylorus, or the length more than 16 or more millimeter of the pylorus length. So it's suggestive of the pyloric stenosis in children. So you need to do ultrasound as well. Okay, next. Okay, so I think I've mentioned. So this is liver function test. So you can read. I get it from Nelson. So differentiate hepatic cause and obstructive cause. Okay, then next. Okay, my summary. Okay, mention prehepatic. This I got from biochemistry textbook. Hemolytic anemia. I think the same. I've mentioned about hemolytic anemia, the difference between prehepatic, hepatic, and posthepatic. So you can check. Okay, next. So for the management, I think it related to the respective etiologies. Okay. If pyloric stenosis, you do pyloromectomy. Okay. So if I think that's all from my presentation. So this is my reference. All are online textbook. Okay. There any question?
Any questions from the group?
Azlan, did you mention before that liver transplantation is the definite management for biliary atresia?
Yes, I do. Go back to the slide. Biliary atresia. Yeah, it's important for us to know, even if we are not in pediatric posting later on, or you become GP ke. Okay, so yeah, biliary atresia.
Okay,
So liver
How
transplantation. Okay.
how common is biliary atresia?
How common?
Itu soalan doktor ke? Tak doktor.
Okay, doctor, can you answer that?
Presenter lah, presenter. What's the frequency?
Okay. Yep. I need to open back the textbook. Okay, saya Google lah. Saya pun tak ni sangat.
I mean daripada experience doktor.
In Malaysia kan? Yalah. Okay.
Experience doktor kat hospital berapa banyak doktor pernah jumpa biliary atresia?
Biliary atresia is quite common actually.
Oh,
I
okay.
think not in suspect because we don't have that many patients.
Oh,
But
okay.
in other hospital you'll see 1 or 2 per year.
I see. Thank you, doktor.
Okay. I think about the question of liver transplantation, yes, we need to yeah, definite treatment is liver transplantation after he does scan. You get the answer?
Meaning to say after Kasai procedure tu according to bila patient tunjuk show symptoms of liver failure ke atau macam mana, ada specific interval?
Oh, okay. Okay.
The issue is like this. So HIDA scan is basically to diagnose. HIDA scan to diagnose, but you still just HIDA scan is not enough. You will still need liver biopsy, because only with liver biopsy you can know the degree of the disease. Okay, fine. And then Kasai procedure is actually just to buy time, because getting liver transplant is not easy. And because I think, like for example in Malaysia, you cannot do there's a lot of limitation whether you can do cadaveric transplantation or live transplantation. I think in Malaysia you cannot do live transplantation. So so then it's very difficult as well to get compatible donor and so on and so forth. So cadaveric transplant, so where can you get the cadaveric liver? So how many percentage of Malaysian population actually registered as organ donor, for example? How many of you registered as organ donor as well? So how many of us in the hospital registered ourselves as organ donor, for example? So I think getting transplant is actually not that easy. So kasai procedure is to buy time. So but kasai procedure is later you wait for kasai, the more risk for it to not be successful. So kasai, it needs to be done as early as possible, ideally within 3 weeks.
Doctor, I got a question.
Hmm.
In Singapore, in Singapore government, they own our kidney or other organ too?
Huh? You what?
Okay. I did come across about the news. In Singapore, kidney, when we are not your kidney is Singapore government punya until proven otherwise, right? So my question, is it occurs to other part of macam organ lain? Huh?
I don't know, but I don't know about other government, but I don't think doesn't sound true.
Oh, okay.
Hmm.
Kat mana saya sebab saya pun tak ingat sangat, tapi it's quite, kalau kat Malaysia buat macam tu means kidney transplant tu is
No. Tak payah kalau ni, because
okay.
your body is owned by you. I don't know which ruling yang you boleh your part of your body is owned by the government. I think that is I don't know, but that doesn't sound true at all lah. I have families. I have families in Singapore, so I've never heard of that.
Oh, okay. Sorry, doctor. Is it lawful or not? If the news is true.
Law depends on the country, but then your body is part of a human right. That is against the Human Rights Act.
Okay, doctor.
Okay, any other question? Okay, I think that should be enough. If we have any other question, I think we still have some other sessions we can discuss furthermore. And I think okay, let's end our session with tasbih kafarah suratul Asr. Okay.